Yeah, we see it.
All right. Good morning, everybody. Today I'm going to present a case, very interesting case I actually encountered during my one of my ICU's rotations. Patient is 44-year-old Hispanic male, presented with acute onset of right arm weakness that started around the 10th. He presented on the 10th of last month to outside hospitals. His symptoms started a couple of days before his presentation to outside hospitals, but he did not decide to present until like 3 days later. His review of system was positive for mostly a couple of weeks of appetite loss, weight loss, and hoarseness that started almost like 10 days before his presentation, and left neck pain. Physical exam was mostly positive for right arm weakness, was proximal more than distal, and right leg weakness was the arm was weaker than the leg, and then he has some nasolabial flattening, slurred speech, and he had really significant neck swelling as well on the left. His labs were remarkable mostly for like really bad persistent leukocytosis in the 40s to 50,000s. His MRI at outside hospital workup at outside MRI brain showed, as you can see, there is a watershed infarct in the MCA territories, and there is some small also in the left MCA territories, and then like there is one as well in the right MCA territory, but it's mostly in the left that explains his weakness that presented. This is his flare signals on the MRI, as you can see, redemonstrating the stroke itself. Vessel imaging that was done at outside hospital, actually, the CTA head and neck. As you can see, there's very large aneurysms in his left ICA over here. Can you see in the imaging, there's a thrombosis inside the ICA aneurysm. Hope it's clear over here. Very enlarged aneurysm with a thrombosis. So that was thought like the etiology of his stroke. His intracranial vessel imaging was completely unremarkable. There was no aneurysm or anything intracranially. This is the same imaging as you can see in the different cuts over here. And this is the axial imagings of the same aneurysm. And you can see how very enlarged the aneurysms actually measured around 4.7 centimeters over here. And then you can see there is like some weird soft tissue around the areas. Then they did actually, based on the aneurysms of that, they did a CTA as well, AAA. As you can see, the brachiocephalic artery, there is some aneurysms over there with some pressing on the trachea over here that causing like the hoarseness for him. The same things over here redemonstrating this this brachiocephalic artery, like this brachiocephalic aneurysm with a pressing on the airways. This is actually, as you can see in the aortic arch as well, there's a small aneurysm, like there's some aneurysm and irregularity. You can notice the irregularity is actually in his whole arch, the brachiocephalic and the ICA aneurysms as well over here. The reading they found, like, as you can see, this is redemonstration of the whole aneurysms. He had left common carotid, his aortic arch, his brachiocephalic, and as you can see as well, very distally, infrarenally, he has as well aneurysms in the infrarenal, distal aortic and proximal right common iliac arteries. So got transferred over here directly to Duke for further care. TEE was further workup. TEE was positive for PFO. CT chest abdomen pelvis positive for PE. He was started on heparin drip, giving the PE and giving the thrombosis in the ICAs as well. So, and they were not sure what's causing the aneurysm. They thought it's possible vasculitis, actually. So they gave him 2 doses of pulse steroids and then transferred over here. When he got over here, initially was admitted to the floor and then got transferred directly to the ICU, giving the large ICA aneurysm, neck swelling as well. You can see a pulsating actually in his neck. And there was like the hoarseness as well. So they were transferred to the ICU for further care and monitoring. Repeated the CTA actually for him, couple days, like that was 5 days interval only from first CTA. And there was a really significant increase in the size of the aneurysms, went actually from 3.9 to 4.7 centimeters, the aneurysm in the left ICAs. The whole aneurysms in the whole aortic arch, brachiocephalic as well, they all got enlarged. And actually his hoarseness and shortness of breath progressed to the degree he required intubations, because he could not lay flat at all. The moment he was just like slightly flat, he would just get extremely short of breath. So end up being intubated actually. And then ID, rheumatology, both were involved. Rheumatology were like, well, this is not very consistent. Like the rapid progression of the symptoms and the aneurysm growing very quickly. It was not really, it's not very classic for vasculitis. ID, they were like, well, this could be mycotic, we're not sure actually. But the thought, like being that rapid progressive, the thought like this could be more mycotic aneurysm more than vasculitis. So the steroid doses were actually decreased. We decreased him to prednisone 20 milligram daily initially, and he was covered with extensive broad spectrum antibiotics. CT surgery were like consulted for the aneurysms, but they were like, well, we don't feel super comfortable right now operating on him, not knowing the final diagnosis at all. So he finally underwent actually vascular surgery, decided to take him to the OR to fix the ICA aneurysm, and they put a graft insertion with the vascular surgery. They said actually upon opening the neck, that he was lucky enough the aneurysm was already ruptured, but it was only contained ruptures in the area of the neck. So blood cultures from the OR, they all actually came back negative for any organism. All his blood cultures came back negative. This is a pathology report this is a pathology picture actually came from the OR. And as you can see the vessels, and you can see there's extensive lymphocytic infiltrations around the vessels. And there's some laminar necrosis as well. So we get closer with the imagings, and you can see like the extensive lymphocytic infiltrations. There was some pockets of neutrophils, but they were not significant. But then there was unbelievable infiltration of the lymphocytics. So the biopsy results, as by the end by pathologists, rated as a diffuse lymphohistiocytic organizing vasculitis, actually, with a severe laminar necrosis. Rheumatology, they thought this is mostly consists with a probable Behçet vasculitis, actually. And they thought this is on the spectrum, like extremely rare variants of Behçet vasculitis called the Hughes-Stevens syndrome variants. His hospital course, finally, he actually, his aortic arch and his transverse aortic arch was repaired completely with the CT surgery. CT were like, this is one of the most impressive vasculitis I've ever seen. It was like extremely inflamed when they opened him up, basically. So that's why they wanted him to be extremely aggressive treatment with the rheumatology. So he got extensive doses of steroids, and he's right now currently receiving infliximab, and he's doing well, actually, recovering well. I thought like just want to touch base very quickly on Behçet. It's immune-mediated vasculitis, affect both small and large vessels. Usually, that's the things we're like, it's well known for us, it consists with this ulcers in the mouth, genitals, and uveitis, but this case actually did not have any of them. Its origin is usually unknown, and the diagnosis of Behçet is usually mostly relies on clinical pattern. There's no lab specific for it. Treatment corticosteroid and immunosuppressive. Hughes-Stevens syndrome, honestly, it's extremely rare. There's only 40 cases in literature reported. And it's very rare variant to consider of Behçet. It's mostly like consists of vascular occlusion, like you have to have DVTs, which this guy has as an IJ, he has as well his PEs, he has arterial aneurysm and vascular occlusions. And there's usually no ulcers or uveitis. The only thing I found actually about this, like Hughes-Stevens, it's usually like most of the aneurysms should be pulmonary aneurysms, which this gentleman did not have. So that's why I'm not sure if rheumatology felt extremely 100% confident about their diagnosis. And that's why they're mentioning it's probable diagnosis of this. And the treatment for this syndrome is exactly as the same as Behçet syndromes with this aggressive immunotherapy. I think that's the case I have for you guys today.
Okay. Thank you so much.
Thank you very much.
Wonderful case and wonderful care. I'm going to turn it over to Sujay now to introduce the grand round speaker for today.
Thanks so much, Rich. Appreciate it. I have the honor of introducing Dr. Laura Caligiuri, who's going to be speaking today. Dr. Caligiuri joined us from the Temple School of Medicine. And prior to that, she was at the College of William and Mary. She has had a very productive 5 years with us, including a QI project looking at safety for our EMU patients, and also looking at some scholarly activity looking at CBD and how it affects children with practical epilepsy that are on clobazam and valproate. She has been the administrative chief this year and has had the tough task of scheduling everybody that comes through, including our SARs and chiefs on the adult neuro side, and keeping people happy at the same time, which is a difficult job, but she's done a fantastic job doing it. She will be going on to do a critical care fellowship at Northwestern next year. So very excited to see all the great things she does in the future. Her talk today is going to be about post-cardiac arrest neurologic care in the pediatric population. So welcome, Dr. Caligiuri. Turn it over to you.
Great, thank you so much. So I'm just going to go ahead and get everything on. right. And okay, can everyone see my screen?
Looks great.
Yep, looks great.
Excellent. Well, thank you so much. As Sujay said, I'm going to talk about post-cardiac care in the pediatric population, obviously with a focus on the brain and neurologic function. Just a brief outline. First, going to speak primarily about the incidence and etiology of pediatric cardiac arrest, and then discuss post-arrest syndrome as it affects the brain, temperature management and therapeutic hypothermia with a specific focus on our latest trials, as well as neuromonitoring and seizure, and then briefly on prognostication, as this is its own topic entirely. So who experiences cardiac arrest? If you Google image, as I did, it'll be a whole bunch of people in either grayscale or blue scale with glowing red hearts, but in reality, obviously not the case. But both in-hospital and out-of-hospital data are similar when you compare the entire population as a factor of pediatrics versus adult, which is 98% adults and 2% pediatrics. Now, I am going to discuss cardiac arrest throughout this in both out-of-hospital and in-hospital because the etiologies themselves are quite disparate in what causes and also in their outcomes. So even though we only see approximately 2% of cardiac arrest from pediatric patients, that still represents approximately 15,000 children each year for in-hospital cardiac arrests and 6,000 for out-of-hospital cardiac arrests. Of those that are in hospital, if we include recurrent cardiac arrests, there's about 20,000 cases. And again, of those 15,000, 7,000 are pulseless, whereas 8,000 are receiving CPR for bradycardia with poor perfusion. So why do we need to focus on pediatric cardiac arrest on its own as opposed to just the adults? So as we always say in pediatric, kids are not just tiny adults. What's different for them? Usually the cause is different. And then also how it affects the brain. So it's theorized that in this period where you're undergoing neuronal maturation and synaptogenesis, there's a higher metabolic demand in cerebral flow, and therefore a higher risk of ischemic injury and propensity to ischemic injury. So who experiences out-of-hospital cardiac arrest? We will start with out-of-hospital. This data is from the Resuscitation Outcome Consortium of 2009. Now, there has been some repeat data that's all fairly similar. What we can see is that in those less than 1 year, there are 78 per 1,000 individuals who end up having an out-of-hospital cardiac arrest. The next group is the 1 to 11 years, which is 4 per 100,000, 12 to 19, which is 6 per 100,000, and then above 19 years, which ranges between 70 to 95 per 100,000. What we can see here is that the incidence of cases is quite similar between our infants and our adults, but obviously we have much fewer infants in this world than adults, which explains our 98%. So how do they do with out-of-hospital cardiac arrest? Again, this data is from the Resuscitation Outcome Consortium. So what we see is that our middle groups do all right. Now, survivability is definitely low in comparison to in-hospital arrest, but we're looking at about 9%. When we look at our youngest group, the less than 1 age, we do see a poor survivability of about 3%. This primarily can be attributed to the fact that about a third of these cases are SIDS cases, or sudden infant death syndrome. So whereas our older kids may have sudden cardiac arrest that you are witnessed or more likely to be witnessed, these children have a tendency to be put down for a nap or for the night, and then parent unfortunately finds them in the morning lifeless. As you can imagine, the outcomes are then poorer. If we do remove that 1/3 of individuals with SIDS, then our outcomes are similar between our infants and their older pediatric counterparts. Now, what is the etiology of pediatric out-of-hospital cardiac arrest? This data is from the Thaka trial, which we'll go over later, but pretty much every child in this scenario had chest compressions for 2 minutes, so did survive their initial resuscitation. So I do want to point that out. What we'll see here is that there are 25% and 31% respectively for drowning and other respiratory causes, or effectively 55% of cases are respiratory in some way. And then if we look right above that, we'll see the ALTI and SIDS, an ALTI apparent life-threatening event. And SIDS, we just discussed, we can't say exactly what the causes of these are by definition, but we'd be remiss if we didn't talk about, or at least strongly consider, respiratory causes. In fact, the Back to Sleep campaign that people are probably familiar with SIDS that did such a great job in reducing incidence was focused on reducing smothering and respiratory causes of death. So if we include that group too, we can see what a tremendous proportion of individuals are experiencing out-of-hospital cardiac arrest because of respiratory causes. Compare that to the 12.5% from cardiac, and you can imagine how different that is from adult, where it's 70 to 85%. I do want to quickly point out that throughout my research, one of the things that has been very variable is the incidence of cardiac arrest from trauma. In this data, I believe it's included both that drowning is sometimes included in trauma, and then this other unknown. We've seen data anywhere from 6% up to 26%. So I believe that is being right now held both in that drowning and other unknown category. So how do these individuals do from a brain standpoint? Going back to our little family here. Basically poorly based on this data, and I'll explain a little bit more. This data is a Japanese population-based study of 950 out-of-hospital cardiac arrests. Now, what you can see is that we have very low survivability. However, these individuals in this data includes those individuals who, again, did not survive their initial resuscitation in the emergency room. So what about the people who actually make it to neurology and that we end up seeing? For that, I'll bring us to the PCARN data, or the Pediatric Emergency Care Applied Research Network. A bit smaller, but they had 138 children that they recruited from 15 sites, who all received at least 1 minute of chest compressions and then had return of circulation for at least 10 minutes. They had a very different survivability. So survival to discharge was approximately 38%, much better. Of that group, the survivals, 56% had a favorable neurologic outcome. And we're defining a favorable neurologic outcome with a pediatric cerebral performance category score, or PCPC score, of 1 to 2, or no change from baseline. And I'll go over what that means in just a second. What you can also see here, though, is that a third did have very severe disability, which is defined as a PCPC score of 4 to 6. So because this is going to come up a couple of times, just wanted to show you that now. What you can see is it's almost similar to the Rankin scales, where 1 is normal and 6 is dead. And there's that giant gap between 3 and 4, where 3 is moderate disability of an age-appropriate independent child who has special needs, to a conscious but completely dependent child with impaired brain function. So in general, most studies that are talking about a good outcome pick these first 2 or 3, and then a poor, the bottom 3. All right, so what about in-hospital cardiac arrest? Now, at first thought, you might think that these children would do worse because they have an underlying etiology that caused them to be in the hospital in the first place. But that's not the case based on all the assistance and support that they have. So in-hospital cardiac arrests occur in about 1 to 6 of pediatric patients who are admitted to a hospital, about 3 to 6% of the ICU, and that's included in that full population. 85 to 90% are already in a monitored setting, usually in ICU, when they have their cardiac arrest. And 80% of those already have an airway in place, which sure helps out just in case you need a little bit of squeeze. You can see that the survival is significantly improved there too. 40 to 50% survived until discharge with a favorable neurologic outcome. In this situation, we are talking 1 to 3 of the PCPC scores in 80 to 90% of individuals based on this data. So what is the etiology of in-hospital cardiac arrest? It makes sense that it's a little challenging to identify a single cause for many in-hospital cardiac arrests, especially given the medical complexity of these individuals. And the data supports this. And you can see with these percentages that if you add them up, the value definitely exceeds 100%. And it's for this reason. Still, even with that, you can see respiratory causes are still prominent, although not necessarily predominant anymore. we have our cardiac and CHD, or congenital heart disease, not congestive, congenital heart disease, taking up a decent proportion. I also want to point out that they did include hypovolemic shock and septic shock in the cardiac causes, which some would perhaps put in other spots, but of course, in the end, it is cardiac. So in summary of our causes of cardiac arrest and what they look like, out of hospital are primarily respiratory, where in hospital, the etiology is much more varied, respiratory and cardiac. Survival out of hospital is about 3 to 9%, whereas in hospital is 40 to 50. And then a favorable neurologic outcome is very variable in out of hospital. Poor unless you survived your first resuscitation, and then it can be as high as 56%. Whereas in hospital, this favorable neurologic outcome is about 76 to 90%, even with their pre-existing comorbid conditions. So you had your cardiac arrest. Now what and why is neurology being called? Because everyone likes working with us, but also because of post-cardiac arrest brain injury. So in adults and children, post-cardiac arrest brain injury is the leading cause of morbidity and morbidity in the post-arrest populations. In one study of those who did survive their cardiac arrest to make it to the ICU, but then subsequently died in the hospital, brain injury was the cause of death in 68% of those who had out-of-hospital arrests and 23% who had in-hospital cardiac arrests. Now, this does include withdrawal of care because of poor neurologic outcome, which is the most common reason that families opt to withdraw care. So what does post-cardiac arrest brain injury look like? You all know this, but I'm going to say it anyhow. Coma, cerebral edema, seizures, myoclonus, PSH, and long-term behavioral and functional deficits, which is usually the biggest fear of our families in the pediatric population, just from experience. So the mechanisms, we tend to think of hypoxia and hypoperfusion as the leading cause of brain injury, and this certainly is the case in the immediate setting. However, brain injury can continue to develop, especially over the next few hours to days and for 72 hours from reperfusion as a result of that reperfusion. We're so used to these pathways causing us cell death, and this definitely continues to be the situation in our individuals who are undergoing cardiac arrest and healing from their cardiac arrest. This is a little flow sheet that I appreciated from Dr. Elmer, who, this is adult data, which you can tell from this, or adult at least primed from the prevention side. But pretty much up here, it shows what is exactly happening to the brain, and then down what we can do about it. Now, there's a lot of stuff that's listed and a lot of things that it says that we can change. However, as we go through these and you go through the data, there's so much information still to be found. So I'm going to primarily talk in this talk about hyperpyrexia, seizure detection and treatment, and then we'll talk a little bit about delayed prognostication. While I'm here, though, I do want to mention the autoregulatory and cerebral hypoperfusion as an example of how much we have to do and how much we still have to learn about both pediatric cardiac arrest and just cardiac arrest in general, and that post-cardiac arrest care. So we know that cerebral autoregulation of blood flow can be absent or shifted after cardiac arrest, and that the brain is particularly sensitive to hypotension and may require higher arterial pressures to maintain the normal blood flow. That's especially true because the microvasculature is also dysfunctional after the initial insult. So it would seem reasonable that increasing blood pressure would actually go ahead and increase your, improve your outcomes. However, hyperemic blood flow is also problematic and can cause worsening. And unfortunately, we don't have broadly applicable strategies to determine the optimal cerebral perfusion pressure at this time. Some of that data is being worked on for adults that is not existent in pediatrics, nor do we have really a great way to detect in real time presence of hyperemia or hyperperfusion in each area. So when we go to the AHA's version of this flow sheet, and this was something that the AHA put out guidelines for post-cardiac arrest care in the pediatric population for about the first time in 2019, we see the same thing. There are these gaps where they mention the autoregulation cerebral blood flow as areas that we can improve, but we don't really have great ways. I also mentioned hyperoxia and hypo and hypercarbia. So specifically for hyperoxia, there were 3 small pediatric studies that showed really dependent on the oxygen levels, there were really no change. In 2012, there was a study of 1,875 pediatric patients who had normoxia after ROSC, and that was defined by a PaO2 greater than 60 and less than 300. That did have higher rates of survival, but that has not been repeated to this time. We also know that there's post-cardiac derangements in PaCO2, and they're very common. Now, this could easily affect and exacerbate the ischemic insult through hypocarbia-induced cerebral vasoconstriction or through hypercarbia-induced vasodilation and edema. But what does it actually mean for these patients? There was a prospective observational study of 223 children, and both hypocapnia and hypercapnia were associated with increased mortality, whereas a retrospective study of 195 showed that neither made a difference. Again, there's so much to learn. So where do we have a little bit more information? And that's primarily in targeted temperature management, EEG monitoring and seizure, and then a little bit on prognostication, as I said. We know temperature post-cardiac arrest can be very variable, often with some autocooling and then fevers. And it's well established that pyrexia is associated with worse outcomes. One adult study of 151 patients enrolled following an out-of-hospital cardiac arrest showed that each degree of Celsius higher than 37 had an increased association with risk of severe disability, coma, or a persistent vegetative state. With that in mind, therapeutic hypothermia is in play. And actually, I got to learn through this that individuals have been attempting this since 1928 and through the 40s with very variable outcomes at that time. It seemed that really in 2002, the adult data really seemed to improve. And I know you guys know these trials well, so I won't go too detailed, but pretty much that therapeutic hypothermia improved neurologic outcomes in comatose survivors of out-of-hospital cardiac arrest, specifically with VFib and VTAC. What I thought was really impressive was that the number needed to treat was only 6, and that was true hypothermia, not normothermia. Then in 2013, a randomized controlled trial of 939 participants demonstrated that cooling to 36 with active fever avoidance were similar to those who were truly cooling to 33 without benefit of going to that colder temperature. So with that data, and of course what we know about our neonates, can we use it for pediatrics? Well, we needed our own data. And so we went to a trial called the Therapeutic Hypothermia After Pediatric Cardiac Arrest, or Thaka trial. Was it necessary? Yes. Again, we can't just extrapolate from adult data. Also, what we were seeing were worse outcomes in pediatric TBI with therapeutic hypothermia. And so we were concerned about, obviously, in the cardiac arrest population. Plus, there were many observational studies that had failed to show improvement with therapeutic hypothermia. So the Thaka trials were divided into out-of-hospital and in-hospital cardiac arrest. The out-of-hospital study was done first, and I'll be going over that in more detail. So this was a randomized controlled trial involving 38 children's hospitals throughout the USA and Canada. To be included, children had to be between 48 hours and 18 years of life, have received at least 2 minutes of CPR, and remain dependent on mechanical ventilation following the event in order to qualify. They were able to get 1,335 individuals enrolled, but only 475 were eligible for randomization, with ultimately only 295 being randomized. The major exclusion criteria was primarily difficulty or inability to undergo randomization for any reason within that first 6 hours after return to circulation. Also, if there was a motor response subscale of 5 to 6 on the Glasgow Coma Scale, individuals were considered to be too healthy to undergo these trials that would require sedation and sometimes paralytic. Other reasons that individuals were pulled out, of course, if the team decided that this aggressive treatment was not in the patient's best interest, or there was major trauma associated with the cardiac arrest. Randomization was stratified by center, as well as age, with the subgroups being less than 2 years, 2 to 12 years, and then greater than or equal to 12 years, up to 18. So what did they do? There were 2 primary groups, 2 primary treatment arms, and each treatment was maintained for 120 hours. The hypothermia group was cooled to a goal core temperature of 33 degrees for 48 hours. They were then rewarmed over 16 hours and continued at the same normothermia for the duration of those 120 hours. They were all sedated and then paralyzed if needed. Cooling blankets were placed front and back. The normothermia had pretty much the same setup, except they were brought to 36.8. And again, paralyzed and sedated if needed. You can see on their data that every once in a while, very slightly, the normothermia group gets to 38, but primarily it stayed under. So what was their goal? Their outcome was survival with a good neurobehavioral outcome at 12 months of follow-up. And the way they defined a good neurobehavioral outcome was by having a 70 or higher on the Vineland assessment or VABS-2. The Vineland is one of our testing methods that allows us to investigate multiple components of functioning. You can think of the score almost similar to an IQ, where 100 is the mean. It's great because if you have someone who's very well trained in the Vineland, there are multiple domains that it looks at, including communication, daily living skills, socialization, motor skills, and maladaptive behavior. What is unfortunate about it is it does take that training, and also it is behind a paywall, so I'm so sorry, but I do not have a copy. And again, they did get these individuals primarily to show up at 12 months for follow-up. So here is their resultant data. What you can see is that although it appears when you just look at it that the hypothermia group may have had a better primary outcome, it is not statistically significant. Survival to 12 months also is not different, although survival over time was considered to be significantly longer with therapeutic hypothermia. The therapeutic hypothermia mean survival was about 149, whereas the normothermia group was 119. Of course, in interpreting this data, we have to remember that both groups received an active intervention in the form of temperature management. Now, were there adverse events? Yes, but pretty low. Infection, bleeding, and arrhythmias were the same between both treatment arms. Hypokalemia and thrombocytopenia were seen a bit more in the hypothermia group, and renal replacement was required more in the normothermia group. So they were effectively considered to be equal levels of safe. So the Thaka Inhospital trial was also done. It was a very similar format with 329 randomized patients, 166 in the hypothermia group and 163 in the normothermia. Same procedure of going to 33 or 36.8 at the exact same times, 48, and then cooled for rewarmed for 16 and held on for 120. And ultimately, this study was terminated early due to futility. There was no difference in survival at 12 months with the Vineland greater than 70. So what conclusions can we get from these studies? The main one is avoid fever, including if you have to use active temperature management to do it. We cannot use these studies to support any significant benefit at lower temperatures or active therapeutic hypothermia. And also, although there was no difference between these two groups, we have to consider the possibility of a false negative with the wide confidence intervals. Now, the Pediatric Advanced Life Support does recommend therapeutic hypothermia from 32 to 34, or therapeutic normothermia from 36 to 37.5 for 48 hours following a cardiac arrest. But there's still some room for interpretation and individuality in each institution. So I would be remiss in talking about therapeutic hypothermia without at least putting one slide in about our babies. All this data has been 48 hours or older children. So what about our neonates? I say neonates are just different. Their brains are different, the way they work are different. So it makes sense that their treatments are going to be different too. It is now standard practice and has been to cool individuals to 33 to 34 for 72 degrees Celsius for 72 hours. That's based primarily on the TOBY trial, which is the total body hypothermia for neonatal encephalopathy. I cut off a couple letters there, which was a multi-center RCT, 325 individuals who were 36 weeks or more at birth, who had various reasons for birth depression. Cardiac arrest was one of them, requiring compressions, but also low APGARs, encephalopathy, poor lactate and pH. Now, they did actually, their primary outcome of this study was rate of death or severe disability, and they were actually identical across the groups, or statistically identical. But cooling did show a significant increase in the rate of survival without neurologic abnormalities, and they improved the neurodevelopmental outcomes in survivors. And there they used the Bailey scale, which is similar in theory to the Vineland. Okay, so that's our main with therapeutic hypothermia or targeted temperature management. Now, what else can we do for our patients? We need to think about seizures and EEG monitoring. So we know that seizures increase the metabolic demand and contribute to neuronal cell death, especially in an already stressed brain through enhanced excitotoxicity. Plus, if we are undergoing therapeutic hypothermia, there may also be shivering, which necessitates or could necessitate neuromuscular blockade and further indicate EEG monitoring in case there are subclinical seizures or if you are paralyzed and have neuromuscular blockade. Seizures. We know that seizure myoclonus or both occurs in 5 to 15% of adult patients who do achieve ROSC and 10 to 40% of those who remain comatose. The data is similar in the pediatric population, so 10 to 40% of children who are critically ill and encephalopathic in the PICU, not necessarily cardiac arrest, but 10 to 50% specifically after ROSC in the setting of cardiac arrest as well. So there are a lot of questions that come up with EEG monitoring post-cardiac arrest. And I think one of the ones that I was definitely struggling with lately was, how long do I need to keep this patient on? So there was another lovely recent trial. This was a recent observational study published in Neurology that aimed to fill this gap, how long you need to watch your EEG to identify seizures in these critically ill children. Although it was not specifically designed for cardiac arrest, our patients do tend to fit into the critically ill category, so I wanted to discuss it. The study question was specifically, how long should critically ill children undergo EEG to detect electrographic seizures? Of note, they did exclude neonates, which in this setting is the less than 30 days. Those in the ICU because of routine postoperative care from epilepsy surgery, and patients who were transferred to this particular quaternary center for known status epilepticus. So they found that they had electrographic seizures occurring in 26% of their children who were screened, or 184, which is it within that range of the 10 to 40 that we were expecting. So how did they figure out how long you need to watch? Well, one of the avenues they did was to investigate how likely an individual was to move from a benign state to a state of risk or seizure. So they created these 3 states. An entry state, which was effectively normal or could have slowing but no epileptic activity. An EEG risk state, which was defined by the occurrence of specific EEG features that predispose to seizures, like sporadic epileptiform discharges or BIRDS, periodic discharges, lateralized rhythmic delta, and spike waves. And then, of course, electrographic seizures, which is the ES state. In this, you can move from green to yellow, yellow to red, or green to red, but you can never move back, because once you move up in the setting, your chances of having electrographic seizure and needing additional EEG are permanently changed. So when they started this and they just put the EEG on, they found that 682 patients were in their entry state, 21 were in the risk state, and 16% were having electrographic seizures at the time the EEG was placed. So for this study, those 16 go away because, again, once the electrographic seizure is identified, we can take over how long the EEG needs to be on, since it's no longer a screening. So how many patients went from the entry state to the epileptic seizure state directly? Only 64 patients actually made that move, which was a probability of going from that state of 0.094. It occurred in a median time of 1 hour, although the range was within minutes to about 4 hours. There were a number more individuals who went from this entry state to the EEG risk state, and that was 230, with a probability of transitioning of 0.338. The median time that this occurred was approximately half an hour, with a range of minutes to 4 hours of that interquaternary range. And then finally, going from EEG risk state to electrographic seizure. Again, I'm showing 251 patients because there were 21 who started in this group, and then 230 came over from the entry. 104 individuals made this move over, which the probability of transitioning was 0.414, with a median time of about 2 hours and a range of about 15 minutes to 7 hours of that interquaternary range. So what does that look like? They made these beautiful, colorful plots called swimmer plots to give us a better idea, and divided it into age and prior seizures, so effectively risk stratification. Now, if we're looking at these, the y-axis is effectively each bar is an individual, and the x-axis is the duration from 0 to 72 hours. You can see that someone gets a green if they're in the entry group, yellow if they're in the risk, and then red if they're in seizure. So it will progress along that way. Unsurprisingly, we see the most red in the age less than 1 year with prior seizures. This is supported by their next step, which is the proportions. So here again, you can never go back. So things can only keep kind of going more towards the seizure, but you see that they eventually, each curve starts to level off. Now, some of that is because the EEGs were also discontinued. This was an observational study. So it was up to the bedside team how long to keep the EEG on. What you'll notice is that not everyone made it to the 24 to 48 hours that they were actually planning and expecting people would be on EEG. In fact, the median duration of EEG monitoring was only 23 hours. So can we still elucidate any information from this? The answer is yes. So one, we show that we have a high incidence of seizure in the acutely ill and encephalopathic child, a pretty high incidence that you definitely want to screen for this. And then also, if you look at this table, they were able to use their data to create a stratification for risk and how long you need to keep an individual on EEG in order to be either have a chance of having electrographic seizures less than 5% or less than 2%. What we can see in our lowest risk group of greater than or equal to 1 year, who've never had clinically evident seizures and whose EEG still looks good without risk, you could have them on for as little as 6 hours, and there would only be a less than 5% risk that they would go on to have an electrographic seizure that you missed. If you want to take that to 2%, you'd have to keep them on for 24 hours. Now, for situations where we're dealing with financial burdens and hospitalizations for families, that could be quite significant. Also for those who are critically ill and moving from different settings. Now, if you have individuals who are less than 1 year of age and have seizure, they may actually need to be monitored for longer than that period of 48 that we tend to think of. They mentioned 2.5 days, and I've also seen 3 days, especially for billing purposes, to just complete it out. So again, this is for EEG. There are a few other strategies that we can use, and one that I just briefly want to mention is sedation and neuromuscular blockade. There's no high quality evidence to pick which agent you're going to use for children with post-cardiac arrest syndrome. If there is shivering, we tend to go with opioids, benzos, magnesium, or Depakote if we're not doing a neuromuscular blockade. And then of course, I do want to, anything that brings us up, wants to mention that you need to be aware if you're using these with therapeutic hypothermia, you should be talking with your pharmacist since they do not have the same pharmacokinetics. Okay. I'm very briefly going to touch on prognostication, and that's because this is really its own subject that both has a ton of data and also definitely not enough since each individual is so unique. So I'm going to start with the exam and then mention the EEG. Imaging, I will primarily defer, and if there's any questions, I'll be happy to go over it just because, again, it can be so individualized for each patient, and I know that we do so much of it anyhow. So as far as the exam, one of the things that the multiple prospective and retrospective studies of children have shown, just like in adults we know, is that immediate exam findings at admission are often not predictive of what your outcomes are going to be. But following up at 24 to 48 hours is actually fairly sensitive and specific. So if we look at these studies that are listed, we can see up here first a retrospective study of 44 children who had abnormal mental status, and this was specifically through a near drowning event. When they did the examination 24 hours after the injury, it correlated tremendously well with outcome assessments at a minimum of 6 months. Same specifically, a good outcome or mild or moderate, no deficits was associated with purposeful movement, whereas sensitivity, specificity of almost 100% was a negative predictive value. All children without purposeful movements did have a poor outcome with either death or severe deficits. And again, they're calling that the PCPC of 4 to 6. And 12% actually in that group actually had withdrawal of life support for poor neurologic prognosis on day 4 to 5. We can see right underneath that a prospective cohort study of 42 comatose children after non-traumatic cardiac arrest who had serially evaluated absence of spontaneous, looking for respirations or absence of, looking at their GCS, and then pupillary response. Absence of these at 24 hours also had a positive predictive value of 100% for a 3-year time frame. Again, this is the PCPC from 4 to 6. The next study uses the Glasgow outcome scale, different than the Glasgow coma scale, but you can see that these are pretty much similar throughout. Now, what I do want to mention is that for a lot of our families, at least in my experience, and I don't have the necessary data to support this, that a pediatric cerebral performance category of 4 to 5 may be acceptable to them, and we've seen that over and over again. So this does not necessarily mean death, but just assists with us in providing a basis for families of what their expectations could be and setting new expectations for them of not full recovery. Now that is still pretty early, 24 to 48 hours, especially when we're predicting things 5 years out. But at least from the data that we have, which is very limited, we have seen pretty strong responses. So what about with EEG? With seizure, actually, the data is very variable. So one study of 73 children, retrospective, with cardiac arrest found that all the patients with seizure within the first hour of recording, and then all the children with myoclonic status epilepticus had poor outcomes, again, PCPC 4 to 6, or having the increase of PCPC by 1 from admission to hospital discharge. But then there was another study that looked at 89 pediatric patients in an ICU. It was a prospective observational single study after their cardiac arrest. And for them, again, unfavorable outcomes defined the same, but in this cohort, neither seizures nor status epilepticus, the presence of that was associated with poor neurologic outcome. Therefore, we can't really necessarily use seizures or even status in this immediate period to give families a great idea of where their child will be in the future. What we can use a little bit more, or at least have better data for, is the background activity. So specifically, if there's a discontinuous background, burst suppression, or attenuated featureless background, that has high predictive value of a poor neurologic outcome. And again, some of those studies went off of the PCPC and some went off of the Glasgow outcomes scale. So I am briefly going to mention SSEPs because they have come up in our setting before. And I remember talking about, should we just get these? And we have at times, and they're appealing because they can be done at the bedside. You don't need to worry about sedation or hypothermia, and you can do them multiple times. However, the pediatric data is lacking, some of it in having standards, but also unclear prognosis, even with the absence of that N20 that we see so consistently in adults. The data that we have, there was still poor outcome, 100% predictive value, but it's a little bit less convincing than it is for the adult studies. So what am I hoping people will get out of this presentation? So talking about the incidence in etiology, 1 out of hospital cardiac arrest has worse outcomes than in the hospital. We knew that. In kids, there's a higher likelihood of respiratory or traumatic causes than cardiac, and that can absolutely change how they're responding to different therapies, and explains also our need to continue looking into different therapies for the pediatric population outside of adult. For the post-arrest syndrome, the injury does not end when circulation is returned. Neuroprotection absolutely is key, and we still have many areas that we need to learn about and potentially can take advantage of to improve our outcomes. As far as temperature management, Right now, at this time, therapeutic hypothermia is not indicated in individuals greater than 6 hours and less than 18 years. So it's a big little gap. However, active avoidance of fever is very likely beneficial. And actually, in the Thaka trials, there have been multiple studies following them. One of them looked at the individual institutions who were involved in the Thaka and if it changed their practice. And what they saw was a trend towards putting pads on or blankets on any individual who's coming in with a cardiac arrest and keeping them actively normothermic. So something that would actually be a potential change for our practice. We sometimes do it, but it is not necessarily written in stone here at Duke, or should ever be written in stone, but think about it a little bit more. And then for neuromonitoring and seizures, 10 to 40% of critically ill children with encephalopathy will experience seizure. So that includes our sepsis patients, right? That includes the patient that you're like, really, really? Put it on, screen. And our youngest patients are those with a history of seizure are at highest risk that would need a longer screen. Whereas our ones who are older than 1 and had never had seizure, you could potentially get that EEG off in 6 hours and feel confident that you're not missing a significant epileptic seizure. And then for prognostication, please don't jump the gun. Use your exam, use your EEG, imaging, lab values, and history together. It is so tempting when family is right there in front of you and asking for answers to provide them, but we really need a little bit more time to settle in on these. That being said, there's so much data to obtain and integration to happen. And again, my next slide is neuroimaging if we want, but even then we're not, there's just so many places to go. So here are my references. But I just wanted to see if anybody had any questions or comments and kind of keep this on our little take-home points that I would like, especially our residents, to make sure that they leave with.
Thank you very much. So if anyone has any questions, just type your name or your question into the chat. We have a few minutes. I'll start off, Laura. Does the etiology of the arrest matter? You know, the trauma versus hemorrhage versus stroke versus cardiac?
They certainly can, especially since there's usually a difference in the amount of downtime between like our drowning patients, our trauma patients, and an arrhythmia patient. There are some data about that, but ultimately it does seem to be that the in-hospital versus out-of-hospital makes a much more significant effect. Our respiratory patients out of hospital do seem to do worse than the cardiac patients. Okay.
A comment from Rick Bedlack to remind you that he is a fellow William and Mary alum.
Oh, really? Go Tribe. Okay. Exciting. Usually we don't get them here in North Carolina.
Hey, Laura, I have a question. This is Carolyn.
Yeah.
One of the things that I think is a little better, maybe on the adult side, and people can help me in wanting to know, you know, the neuroprotection, when to put on the EEG, who to put it on. How do we communicate that to our colleagues in varied ICUs, right? The pediatric cardiac, the PICU, the adult, CT surgery. Is this something that neurologists need to better integrate with their ICU colleagues, or is best done by the neurologist primarily on the consult service? Kind of what's your vision to how we can make it so fewer people, adults or kids, fall through the cracks for these kind of important take-home points here?
No, I thank you for bringing that up too. I actually think we've made one small change already this past year to try and address that. And that is anytime an EEG is ordered, we now get notified, whereas before they could just sort of be in the milieu and we would find out when one of our wonderful epilepsy fellows would call us and say, uh-oh, we have a problem. So I think already having that communication and direct messaging that no one has to think about it, it's coming to neurology will be helpful. I do think that we need to be the primary messengers for advocating for neuroprotection, for advocating for EEGs, and probably has to happen both in primarily non-acute settings in the education, and then in feedback when we meet these people and when we come up with these situations, these individuals, the patients. I think that our brain rounds could actually be a great opportunity for that, since we're going over every patient in the PICU and PCICU to pick up on these individuals. Also for our immediate post-cardiac patients, our post-stroke, our status epilepticus, I'm obviously someone who's very much like, sometimes it's just you can't be at bedside every single time, but for these kids who are in the sickest situation, it could be really helpful to, if you can't, even if you can't get to bedside, try and get to bedside, but if you can't, calling the nurse directly, the actual care nurse, and making sure that they understand the importance of these interventions, since they're the one actually doing it, not just the resident or the fellow. And then trying to, I think in our notes, we've now been trying to put little sections of like emergency or acute and bolded, underline things to go right into the pediatrics team's handoffs. And we could probably also continue that action here with the cardiac patients.
Thank you.
Thanks.
Bert, do you want to ask your question?
I don't see it.
So Laura, what Bert said is he would add delayed onset movement disorders to the list of outcomes after cardiac
Thank you.
arrest.
Yes, thank you. And thank you for your help with my movement disorder patients. I did not get to read as much about that in the traditional and like the standard data. So I actually think that that would be a great spot for anyone looking to publish. And in my mind, I'm kind of like, oh, us too, if you get a good cohort,
Okay.
or the pediatric population especially.
Okay. All right, Laura, thank you. It's 9 o'clock. Great talk. And everyone else, stay safe.
Thank you.
Bye-bye.